I'm coming over from Cedars-Sinai over in LA, where I see patients primarily in a primary care setting in relation to celiac disease. So we'll see kind of in a little bit. That's usually like the first place where patients, when they're concerned they may have celiac disease, meet with their physician. And we'll talk through what the questions we maybe discuss at those kind of visits and some diagnostic testing. I'm excited to delve into that a little bit more. So we're talking about celiac disease. To dive right in, how I like to do some of these things, I think sometimes the academic talks, we put the objectives all up front and then we work through everything. But when I was in school, felt like sometimes it's hard to remember everything that's going on, sometimes get a little lost in the weeds. So I like to start out with highlighting some of the takeaways up at the beginning and then also revisiting at the end. So this slide has a lot of key takeaways. Highlighting it with the title is that celiac disease is an autoimmune disorder and it's triggered by gluten in genetically susceptible individuals. So this highlights the current understanding of celiac in terms of it's more of this autoimmune focus with many manifestations throughout the body than primarily just the GI disorder focused on malabsorption. And we'll delve into a little bit more through 3 different sections. We'll start off with the background, then move on to the symptoms, and then conclude with some of the evaluation. To just touch briefly about each of these main sections of the talk, when we talk about the background, we'll see how the prevalence of celiac disease has been increasing over time. Today, it's affecting about 1 to 2% of the population. We'll see how for genetically susceptible individuals, gluten, which is commonly found in grains like wheat, it triggers this inflammatory response in the small intestine of the bowels, which damages the intestinal lining and leads to many of the symptoms and malabsorption of nutrients. And then we'll move on to the second section where we talk about the symptoms, and we'll see how iron deficiency anemia and diarrhea are some of the more common symptoms, but there's several other symptoms that could suggest celiac disease. And because some of these symptoms are a little bit more vague, many patients have symptoms for over a decade prior to their ultimately diagnosed with celiac. And part of that helps contribute to why the average age of diagnosis in the United States of celiac disease is around middle age and middle decades of life. And then after we are presenting with all these symptoms, we'll have in the final section where we talk about the evaluation, we'll talk about the commonly used blood tests for the diagnosis of celiac disease and highlight cases when we may need to do more invasive tissue sampling. And then we'll investigate reasons why, if despite treatment, which is the gluten-free diet, if we're still having symptoms, there's a variety of causes that include the original diagnosis. You may not actually have celiac disease. Perhaps there's some gluten that's contaminating what we think is the gluten-free diet. Maybe there's an additional disease other to celiac, or we have a refractory presentation. So to dive right into the background, we'll talk a little bit more about the prevalence first. And here we have some more information highlighting how the global prevalence of celiac disease is between 1 to 2% across geographies. This figure here highlights several countries where we've studied the prevalence of celiac disease. The colors are a whole bunch of different shades of blue that highlight the variation of prevalence across these countries. The ones in the more lighter blue have a lower prevalence of celiac disease, where the ones in darker blue have a higher prevalence. And what exactly those lower prevalences are, it's around 0.2 to 0.8% in the lightest blue countries. And in some of the darkest blue ones, it ranges anywhere from like 2.1 to 8.5%. Where we're at in the United States, there was more of a lighter blue color. So we're in line with some of the global prevalence of celiac disease, which is about 1.4%. And of course, there's some differences in this prevalence depending on gender, depending on ethnicity, reflective of some of the genetic components of this disease. And you can see the geographic variation in prevalence across these countries. And now what's also interesting is that celiac disease is roughly 4 times as common today as compared to 50 years ago. And this study here, what this data is from, beautifully highlights it. Essentially what they've done, they had some blood samples from folks at the Warren Air Force Base about 50 years ago, and then they collected some samples in similar individuals today. They tested all these blood samples for celiac disease, and they found, if we're looking at the really dark, thick rectangle here, you can see in the historical cohort that the prevalence was about 0.2% back around 1950s or so. And then when they collected samples in more contemporary time period, on the further right-hand side of the big rectangle here, you can see that the prevalence has increased to 0.9% or 0.8%, depending on what comparison group you want to look at. That's a 4 to 4.5-fold increase in some recent cohorts. And what's nice about this study is there's been some arguments that now we're maybe have better tests for celiac disease, and that's increasing the prevalence of the disease. But this study nicely shows that even using the same test on old data, the prevalence is increasing. And there are many possible reasons for this that we'll get into later on. But we'll first highlight some of the underlying biology behind celiac disease. This is a very busy slide, so I'll walk through some high-level stuff here. So what leads to celiac disease is that gluten ingestion triggers an inflammatory response in individuals with a genetic predisposition. So if we focus here on the graphic on the left-hand side, we can start thinking about the yellow wheat. So we're eating some grains, maybe they have some gluten in them. They're coming through the digestive tract, and you see these red-orange Pac-Man-like things coming to take a look at the wheat, and these are enzymes that help digest this. They kind of break it down into parts that enable us to really get the nutrients out of our food. And these come from both our own body and some of the microbiome in the intestine. And they gradually keep working on breaking the nutrients down into smaller and smaller pieces so we can take them up into our body and bring them in through the intestine into ultimately the bloodstream. You can see as they're making their way through the intestine, they're getting into smaller pieces. Eventually, they turn into these more darker blue triangles, and you see this black Pac-Man looking enzyme coming to digest it, which is a key one here. It's the transglutaminase 2, also known as tissue transglutaminase. We'll talk a little bit about it more later because it's involved in some of the diagnostic testing. But essentially, as it breaks down the gluten, it forms a complex with it and also increases the affinity of the deaminated gluten to these DQ2 or DQ8 grooves on antigen presenting cells. So part of the immune system has these receptors that can bind this product as it's processed by the enzymes. And this is where the genetic predisposition comes in. So not all individuals have these DQ2 or DQ8 grooves. This is something that's inherited through genetics and is largely needed for the development of celiac disease. So that's where the genetic predisposition comes from. And then as these receptors are on cells in the immune system, once the gluten products bind them, it starts triggering the activation of the immune system. So you can see in the bottom left-hand quarter, when you have that deaminated gluten complex, it's bound to the DQ2, DQ8 complex on the antigen presenting cell. It can then interact with your CD4, your helper T cells, more part of the immune system. And that interaction creates a few things. You get these gluten-specific B cells that start releasing antibodies, these anti-deaminated gliadin antibodies, which you can assess for in various tests. And it also starts releasing some inflammatory mediators, which are things here you see like IL-15, that causes a lot of inflammation. And the inflammation is really what drives a lot of the symptoms. And we'll explore that a little bit more next here, because it's this inflammatory response. Because now we have the genetically primed immune system. The immune system's been activated. You have all this inflammation now that's going on in the gut. And that's leading to diarrhea via a variety of mechanisms. We're going to highlight three major ones here. So with a lot of that inflammation, we're destroying some neuroendocrine signaling cells, and these cells release a lot of hormones that aid in the digestive process. But it also decreases some of those brush border enzymes. So that's what we were seeing with the Pac-Man figures on the prior slides, which help break down carbohydrates and proteins. We're not breaking them down to absorb them properly. And we also end up losing a lot of the what's known as this tertiary villus structure. There's a lot of surface area on the gut. So we no longer have as big a region that'll help us absorb a lot of these nutrients too. Collectively, all these factors lead to a lot of the symptoms of celiac disease. And now, before I was talking a little bit about, we're seeing this increase in celiac disease across the globe. And there are many possible theories as to why this increasing inflammatory response to gluten is happening. The main ones have to do with big changes in the environment. There's a lot of folks who are thinking about there's been changes in a lot of the quantity, the quality, and the processing of various cereals and wheat and other grains that have gluten in the diet. And they're thinking the body has not had time to adapt to a lot of these changes in our dietary quality that have been happening recently. And that's led to a lot more of this inflammation, and the folks who are genetically susceptible are more likely to develop this inflammatory response. And then there's also been some research that looks at early childhood infection patterns. There are thoughts that there are various viruses that when kids do get infected with them, they increase the risk of autoimmunity. So the immune system becomes primed to start attacking some things. And that also may be leading to why we're seeing more and more celiac disease over time. I've included here a variety of studies that talk a little bit more about this, but that essentially concludes a lot of the background of celiac disease. So we'll move on next to the symptoms, what the common ones are after we have all this inflammation going on. And so traditionally, iron deficiency and diarrhea are some of the most common symptoms, which usually may trigger a diagnostic workup. However, there's a whole variety of other symptoms. I've listed a few of them here. This isn't all-encompassing. There are several more symptoms that can manifest with celiac disease, but some of them include, for example, a short stature, which is defined as a height below the third percentile for age. You could have dental enamel defects, and these could be seen as changes in color to different integrity of a lot of your teeth. And then it's not just the teeth are infected, but it's the bones as well, which is what we see with osteopenia. You have reduced bone health, increased fracture risk, all from decreased absorption of essential nutrients that help strengthen a lot of the bones. And then there's also been described fertility issues, which can include things such as delayed puberty, miscarriages, premature births, epilepsy, some more seizures and frequent seizures from the disease. Also neuropathy, which is like a numbness and tingling of the hands and feet. You can also have some ataxia, which is issues with times when we're trying to coordinate our actions, walking around, makes that a little bit difficult. Then there's this dermatitis herpetiformis, which is a very itchy rash. It's seen as some small blisters on the skin. Some folks find it very debilitating. There's also what's known as this hyposplenism, which is essentially a small spleen, which is something that helps with fighting off infections. So we see in patients with celiac, there's an increased susceptibility to infection. And there's also some transaminitis, which is essentially on some blood tests, it's an elevation in some of your liver enzymes, and folks are usually relatively asymptomatic with that. Sometimes, because these symptoms are vague, that may lead to some issues in actually diagnosis disease. And what we see when we look at the initial presentation of folks with celiac disease, it's most commonly now in middle age after chronic gluten ingestion. Now, celiac disease can develop at any age, so this could be a new loss of tolerance to gluten over time, or it could just be a late discovery. The symptoms could be mild. Folks could put it off earlier on, and then when they're a little bit more concerned about other health issues, come to the doctor and get it worked up. And there's also been improved awareness of celiac disease and easier diagnostic testing, which has helped as well with some of this late discovery component. But as I was saying before, many patients have symptoms for several years prior to diagnosis. Sometimes the symptoms may just be mild, or sometimes it's just tough to really narrow down that diagnosis. And the average age at diagnosis is in that 4th to 6th decade of life. But now it's not just folks in their middle age who present with celiac disease. Children can also be diagnosed with celiac disease. Often it's a more pronounced presentation. Sometimes in these severe cases, early on, they're just not eating. They're just having a lot of issues with GI side effects. And so they're failing to thrive, failing to gain weight, and really not doing so well. And there have been talks and questions about the timing of gluten introduction to the diet effect on the onset of celiac disease in children. And here in this graph, I highlight a study where they look at introducing gluten in various times of a child's diet. And we can see with the red line here, which is group A, that's the gluten at 6 months, and group B with the blue line, the gluten at 12 months. Then as we move horizontally, we see these lines increase, which is highlighting an increase in proportion of children with celiac disease. Initially, the kids who start gluten early on see an increased amount of them have celiac disease. And these are all individuals who have that genetic predisposition. So that's why we're seeing so many folks go on to develop celiac disease in this group. But we see that over time, as the kids get older, the proportion of children in both groups is relatively the same. So the conclusion from a lot of this work is that while introducing gluten early on in the diet may unmask the symptoms earlier and the disease earlier, ultimately in the long run, the delayed introduction of gluten doesn't modify the actual risk of developing celiac disease if you are predisposed to it. So those are a lot of thinking about the symptoms, both in the adults, the children, and now we'll think about when both of these groups, when they are having these symptoms, when they go to the doctor, what the next steps are going to be in that scenario. So here is what the doctor is going to be working through when they're thinking about diagnostic tests. We'll see that blood test, the most common test to diagnose celiac disease. So what happens is if you think you have celiac disease, you have this suspicion for it, you would usually go to your primary care doctor or your gastroenterologist. and they may agree with you. And if we have that clinical suspicion, the next step is to think about what diet we're currently on, because that's going to impact our test results and the test we order. And that's going to be if we're already on a gluten-free diet, because we thought that's going to help improve our symptoms, or if we're on the normal diet. Because the thing is, if we're already on a gluten-free diet, that whole inflammation process we're talking about before doesn't have the chance to be triggered, and we're not necessarily generating a lot of those new antibodies which we're used to test for it. So if we're on the gluten-free diet, what we end up testing for is these HLA-DQ2 and DQ8 entities. And this is what we were saying, is that whole genetic susceptibility to develop celiac disease is what we're really looking at. And so if this comes back negative, this blood test, because you don't have that genetic predisposition to develop celiac disease absent those molecules, it's a pretty high likelihood that you don't have celiac disease. Now, if these come back positive, they suggest we have this possible genetic predisposition, this genetic likelihood to develop celiac disease. Then we move forward with a gluten challenge. So we start reintroducing gluten to the diet, and we see how the symptoms manifest. And if it's poorly tolerated, we consider doing some of the antibody testing earlier on. Then if it's okay tolerated, we really like to get in several weeks of gluten, because that really is going to show us if we are gluten for a while, and then we do the antibody testing, there's a good likelihood that if we have celiac, that inflammation is happening, we'll get a positive response there. So then if we can move back up to the top of this algorithm where we're looking at the folks who are on the normal diet, you go straight to looking at this TTG IgA, which is looking at that antibody with all the inflammation and the gluten that's going on. But we also measure total IgA levels, because we also see sometimes folks have low antibody levels. If the overall antibody levels are low, that may falsely lower the TTG antibody level as well. So you'll see further down on this algorithm, if we do have the IgA deficiency, we do some other tests and other antibodies to help correct for this. And then if it is the antibody, the TTG is negative, we think celiac is unlikely, but if there's still high suspicion, we can move on to some more invasive biopsy testing, which we'll talk about. But then if it's positive, there's a little bit of a difference between what we do in the adults versus children. If it's positive, we go straight for the biopsy in adults. In children, due to some of the invasiveness of this procedure and tolerating it, there's an option if we think the children's a good candidate for a biopsy or not. So they may get a biopsy if they're a good candidate. If they are not, there's some more blood testing, and that's a little bit more involved that we can do to further diagnose celiac. Then we'll move on to what are the more invasive testing. It's done via an endoscopic procedure here that we have a schematic for, and they take tissue sampling from it. So for the endoscopy procedure, there may be some light sedation involved, because what's going to happen is this instrument, this essentially really long camera, is going to go through the mouth, through the digestive system, through the stomach, all the way to the duodenum right after the stomach. It's going to look around, see what things look like there. And then it's going to take very small kind of pinches of tissue, so get a couple of tissue samples from there that they're going to look at under the microscope to really help figure out what's going on at that intestinal level. So what happens in reviewing the intestinal architecture from the small intestine, they can further assess the likelihood of celiac disease. And there's a couple pictures here which show what the normal mucosa, what normal intestine looks like, and what we see in celiac. In celiac, the medical terminology you may hear is villus atrophy and crypt hypertrophy is classic of celiac disease. What that looks like, if we look at the pictures all the way on the right-hand side, we see a lot of this kind of blue pigment, these circular things going on in there, a flat top, an upper portion there. And that's what we're seeing, kind of the top flat portion is the villus atrophy, and the crypt hypertrophy is seeing all this stuff happening down below that flat surface. Because without celiac disease, it looks more like the pink picture on the left, or the black and white picture all the way at the left. You see these wave-like structures going up and down and up and down. So you get all that surface area to help with the absorption. It's not smooth at all, and you don't have this dense inflammation stuff going down at the base. And depending on the degree of changes they see, the doctor is going to look at that and then do this Marsh classification, where essentially 0 is normal, and it's unlikely that it's celiac, but anything where it's not like that would be more considering celiac, with the more severe side moving to the right with a really flat top And that's the workup the doctor is going to do. But sometimes people are still having all of these symptoms. They're eating gluten, they're getting a lot of GI symptoms, but a lot of this test comes back negative. There could be a few reasons for that. There's many gluten-related disorders, not just celiac disease. So on this pathway here, we talk about the autoimmune conditions, and that's primarily celiac disease here. But some people have wheat allergy, so there's more of an allergic pathway that's leading to some of these symptoms. And then some folks have this non-immunogenic, non-allergic, perhaps innate immunity response to components of gluten and can get symptoms that way. And then sometimes the issue is it's not even celiac disease itself. There's several other conditions that have similar symptoms. Sometimes things like irritable bowel syndrome or IBS. Sometimes it's like SIBO, small intestinal bacterial overgrowth, but there's several other GI conditions, sometimes infections. All this can present with similar symptoms. So it's important to really thoroughly think about this, think about the diagnostic testing where you have a lot of these persistent symptoms and the celiac testing shows up negative. And then though, if we do have confirmed celiac disease, the real treatment is focus on the diet. There aren't too many medications or anything else out there. It's really avoiding gluten from the diet, and keeping gluten out of the diet has several positive effects. It leads to recovery of the intestinal lining. You don't have all that inflammation. Ultimately, that improves symptoms. You can get all those nutrients absorbed, and it prevents any further complications down the line. We'll talk a little bit about what exactly this gluten-free diet looks like, but it's always helpful when possible if can get the advice of a dietitian to know what foods are safe and to help maintain a balanced diet despite limitations. A gluten-free diet can be pretty difficult, sometimes more expensive, a little bit more reading on the products. You have to see if things are processed with wheat or not. And then if you're cooking for families, it's sometimes difficult if one member likes gluten, one does not. As much support and education from the healthcare team can really help a lot in this end. But sometimes, despite removing gluten, some folks still have symptoms. That could be perhaps it's a different disease, but it could also be this more refractory celiac disease. And this happens sometimes when we've had celiac for a while, the immune system just keeps getting triggered so often it's in overdrive. So even removing the stimulus, it's still getting the symptoms. And a lot of the treatment for that, they are medications, and they're largely immunosuppressive medications, some steroids to help try and tamper down the immune system to relieve the symptoms. All that being said, there are still several investigational therapies in the works. There's different digestive enzymes people are thinking about, other medications that alter the immune system, signaling pathways involved in disease. And then on the other side, people are thinking about even genetically modifying wheat to help remove the gluten from it, to find ways that we can still consume a lot of these substances if we do have celiac disease without actually getting a lot of the side effects. There are many kind of grains that we think about with gluten and gluten-free. So when it comes to grains with gluten, the big ones are wheat. It also includes barley and rye. Couscous and farro are also in that category. So if we are with celiac disease, these are the types of foods we'd want to avoid. Or if you have any other gluten sensitivities, you may consider avoiding these foods as well. And then the grains and seeds folks with celiac still can consume without symptoms are on the other side of this chart here. There are things like quinoa, wild rice, kind of all other rices like brown rice too, chia seeds, flax seeds, hemp seeds, sesame, corn is all good. Oats are frequently encouraged. The issue with oats is that sometimes when they're processed, they may get contaminated with wheat, so it's important to read the labels and to see what things are processed with. But for most folks, switching the diet to include these gluten-free grains and seeds and avoiding the grains with gluten has a lot of positive effects. Symptoms get away and they get a lot of the nutrients back in their diet. So to help summarize everything, celiac disease is an autoimmune disorder. It's triggered by gluten in genetically susceptible individuals. We went over for background how the disease prevalence is increasing over time, affecting about 1 to 2% of the population. We saw how folks who are genetically susceptible, who have those DQ2 and 8 entities in their body, then can develop this inflammatory response to gluten, which is commonly found in wheat, rye, barley. And through the inflammation, it damages the intestinal lining, leading to malabsorption and nutrient malabsorption. And then in terms of other symptoms caused by this inflammatory process, the big ones, you could get iron deficiency anemia, get some diarrhea. There's a whole bunch of symptoms ranging from fatigue to bone health, the skin rashes, so many manifestations of the disease. And the symptoms can sometimes be mild to pretty severe. And as a result, many patients have symptoms for over a decade prior to they are diagnosed. And most folks are diagnosed around middle age with celiac in the United States. And in terms of evaluation, what that process looks like at one of your healthcare provider's offices, they'll probably start you with some blood tests, either looking at your genetic susceptibility or evidence of that inflammatory process happening. And then more invasive tissue sampling may be needed depending on what those tests show. To help treat, we do gluten-free diet, but sometimes there are symptoms that persist. In that case, we may want to revisit the diagnosis. We may want to think about our foods. Are there any kind of contamination going on there? We may think about if the disease has been going on for so long that it's now refractory, we may need some other medications.